Hi everyone, it's Jason here, and we're going to get stuck into our next video. Today we're looking at psychotic disorders, but we're specifically going to hone in on schizophrenia and look deeply at this illness. Schizophrenia is a really different illness to a lot of the ones that we've looked at, mostly because the illnesses that we've looked at, most of this term, mood disorders and anxiety disorders, tend to have symptoms that we can relate to pretty easily. Everybody's felt anxious at different times. Everybody's felt sad and depressed at different times. But schizophrenia is a very different kind of illness, and it's a lot harder for us to understand. So let's get started. First of all, we're going to talk about the onset. Usually it affects young people or young adults, and this is the case with a lot of the mental illnesses that we've looked at. Most cases seem to appear between age 16 and 30, with the average age being about 25. If a person shares 100% of their genes, however, that means they're actually identical twins. There's still only about a roughly 50% chance of developing schizophrenia. So there does seem to be a really strong biological component with the age of onset and with the genetic element there, but environment also plays a really large role. So if we're trying to look at the causes, yes, there is a high heritability factor and genes are really important, but there's a bunch of other stuff here that seems to be linked to onset of schizophrenia as well. One of the things is prenatal exposure to infections in the womb. Environmental stressors, there's some really big ones here, specifically traumatic events. We know that trauma is a really big trigger for all kinds of mental health issues. We've got their urban environments, dysfunctional families and relationships, and poverty or low socioeconomic backgrounds. And it seems that those things maybe make a person more susceptible to experiencing trauma and therefore more likely to have the trigger for the onset of this illness. Substance use is another really big factor, particularly with cannabis or marijuana. We know that in adolescence in particular, there's a very, very strong link between marijuana use and the onset of schizophrenic symptoms. Cognitive styles is another big one here. So people who tend to make quick assumptions, people who are quick to perceive threat, people who are prone to anxiety or high emotional reactivity, they are also more likely to develop this illness. And some of those might ring a bell from when we looked at anxiety disorders, things like generalized anxiety disorder. So that brings in some of our concepts of dual diagnosis or comorbidity. Lastly, their brain physiology, so structural differences in the hippocampus and the frontal lobes, areas in charge of things like memory and rational thought, and you'll see why when we get into some of the symptoms of schizophrenia, why those areas of the brain might be important, and high levels of dopamine action in the limbic system. One of the big things with schizophrenia is the experience of psychotic symptoms, and psychosis is when the person is kind of losing touch with reality. And it seems that there's a link there between really high levels of dopamine. So it's almost like that pleasure chemical goes completely overboard and runs riot and takes over our system. And we get so kind of high on that dopamine that we lose touch with reality, and it becomes a really intense, quite distressing experience. So what is schizophrenia? It's characterized by fundamental and characteristic distortions of thinking, perception, and affects, or kind of emotions. So it interferes with our ability to think clearly, to manage our emotions, make decisions, and relate to others. And a lot of mental illnesses do that. But the important thing here is the distortions of thinking and perception. So that kind of takes the form, usually, of delusions and hallucinations, alterations of the senses. So the person is struggling to differentiate between reality and what's real and what's not. So there's an inability to sort and interpret incoming sensations. Often there's an altered sense of self, and that ties in with the delusions. And there are changes in emotions, often in the person's movements and obviously in the person's behavior. You might be wondering, what is the difference between a delusion and a hallucination? We'll go into a little bit more detail about that in a moment. So, positive symptoms. When I say positive symptoms here, I'm not talking about, upbeat, friendly, kind of good symptoms. It's not positive in the sense that it's a good thing. It's positive in the sense that it's heightening or arousing the affect or the emotional state of the person. So these things increase the person's level of activity or arousal. That's why we use the word positive. So the key things here, like I just said, are delusions and hallucinations. A delusion is a false belief that has no basis in reality, and a hallucination is a false perception in the absence of any relevant sensory stimulus. So a delusion is believing something that's not real. A hallucination is seeing or hearing or feeling something that is not real, sensory. So common delusions are things like religious delusions, where the person might believe that they're sent from God or something like that. Grandiose delusions, where the person might believe that they are, a secret spy or they're part of some government conspiracy. So they think that maybe they are more important than they really are. And somatic delusions are around bodily things. So the person might believe that they have something implanted in their brain or something like that. Hallucinations are the false perceptions. So auditory hallucinations are the most common, and you can see the picture I've got there, hearing voices. Often people with schizophrenia will hear voices in their heads, different voices maybe speaking to them in certain ways or telling them to do certain things. A lack of control over the hallucinations is a really key feature. So sometimes we can all hear voices, but we can kind of manage that. You might have a negative voice in your mind that occasionally tells you things that you don't like to hear about yourself or whatever it might be. And we can usually cope with that. We can kind of say, in our minds to that voice, I'm not like that. I'm not going to identify with that. I don't believe in that or whatever. But a key feature of schizophrenia is that these voices are really loud and they're really overpowering, and that there's no control over those voices for the person experiencing it. A couple more of the positive symptoms are things like disorganized thinking. So the person might have really disconnected thoughts or disorganized speech. And I'm going to show you some examples of this in a second. The disorganized speech can take the form of derailment, meaning that they're constantly changing from one topic to the next and they never really seem to stay on track with a topic of conversation. Neologisms, which are kind of new invented words that the person might say, words that don't actually exist. Word salad, which is actually a thing. It's a funny name, but it's that idea that the person is talking in a way that the words don't kind of string together into any they don't make any sense, that there's no structure to their sentences and that kind of thing. And sometimes there's also excessive concreteness in their speech. And then we've got grossly disorganized behavior, and that can happen in all kinds of different ways as a result of the delusions and the hallucinations. So hopefully what you can see here, like I was saying at the start, is that this is really different to most other mental health issues. And it's something that a lot of us probably haven't really experienced. So it's a lot harder for us to kind of maybe relate in the same way. And this is part of the reason that schizophrenia, unfortunately, does have a lot of stigma around it, because it's a lot harder for people to kind of connect with or understand the people that are going through this. So here are some personal examples from my life. I've just removed the names and dates and things from this, but this is an old friend of mine called M. I'm calling him M for the purposes of this demonstration, this kind of case study. And M was somebody that I played football with when I was a teenager, and he kind of stopped playing footy and he kind of dropped out of school and, started going off the rails, started smoking a lot of pot, and he was a classic case of that marijuana use triggering the onset of schizophrenia. And he would often change his profile picture to these kind of really odd, out of focus pictures. So there's a bit of an example of that happening there. So we can see some of the kind of disorganized thinking or inappropriate, unusual behavior. And then on the right, we can see some of the disorganized speech. So it says here, lapse 26, better than some coked up event, less chance of bumping into some ridiculous hardware painted idiot, let all our 24 intervals be weekend mornings. That's really hard to decode. I think, after looking at this many times, that he's talking about going swimming and that he did 26 laps, and that maybe he did it on the weekend in the morning, and that he feels like that's a lot more rewarding for him than going to some club or festival where everybody's on drugs and he thinks that they're idiots. But it's really hard to tell. It's really hard to tell that that's what he's trying to say. So we can see some examples there of that disorganized speech, that word salad. Things are falling out of order, and they're not making, there isn't the same clarity that you would expect from normal kind of conversation or a status update. We've got another example here of one of his profile pictures and some more of his posts. On the pass, I hate engravements, though seems most attractive this morning, etc., etc. So you can see we've got some really odd spacing of words, some really odd combinations of words, and he doesn't seem to be in touch with reality in the sense that this is not the sort of thing that people can really make sense of. This is another example from a friend of mine that I lived in Japan with, and she and I used to send a few messages to each other after we moved back to our respective countries, and she had kind of long-term mental health issues, and this was some stuff that she sent me one night when she was experiencing a psychotic episode, and you could probably have a look there. Feel free to pause. I'm not going to read all of that out, but once again, we can see lots of examples of the word salad, of the disorganization of her speech patterns, of the way that she's lost touch with reality. We also see here, and I'll point out, some grandiose delusions. So she says, I'll eat their souls. They will suffocate on their sin for 4 days, a perfect square. So it seems that she has this altered sense of self or her abilities or what she might be able to do in her mind in this situation. So you can pause there if you'd like to look a bit more at that. You can imagine that for me, that was quite an upsetting thing to see my friend going through that. And I did end up getting in contact with some of her relatives overseas, and they were able to help her. At the other end of the spectrum from the positive symptoms, we have negative symptoms. So these, once again, aren't necessarily good and bad, but negative in the sense that they flatten the person's affect. So they make the person less kind of aroused and engaged with the world. So the first one there is flattened affect, and that's kind of the idea that the person is there, but they're almost not there. You know, it's almost like an absence rather than a presence when they're in the room. They might have inexpressive faces or blank looks or monotone or monosyllabic speech and make very few gestures. There might be a lack of motivation or lack of interest in the world. We talked about anhedonia previously, the inability to experience pleasure from previously pleasurable activities. So that happens again here with schizophrenia. And also something that we call alogia, which is poverty of speech. And we saw a little bit of that with the examples with M and my other friend. Alogia is when the person speaks in very short, concrete kind of bursts and doesn't kind of tap into the usual conversational norms. So it might look something like this, an example of alogia. In a typical conversation, if you're out somewhere and you meet someone, or me as a dad, I'm like, oh, hi, do you have any children? And the other guy might say, yeah, I've got a 10-year-old son and a 7-year-old daughter. That's a pretty typical conversation. With someone experiencing alogia, you might say, do you have any children? And they just say, yes. How many? 2. How old are they? 10 and 7. It's very kind of short and concrete, and there's a poverty of speech. That's what we call it. So with schizophrenia and with these symptoms, there are a few different subtypes, and I'll just go through a couple of those now. You might have heard of paranoid schizophrenia. Obviously, this comes with paranoia, especially around the delusions and the hallucinations. And with paranoid schizophrenia, those delusions and hallucinations are always present, but the disorganized thought and behavior and the affective flattening are usually absent. So often this person can still kind of think or organize their thoughts in a generally kind of normal way, but they're full of these delusions and hallucinations. They might feel like they're being persecuted or they're being spied on or something like that. They might hear voices or have visions, visual hallucinations, that kind of thing. With disorganized schizophrenia, that's more of a thought disorder, and the flat affect is often present. And I would say the examples that I showed of M, it's most likely that he was experiencing this kind of disorganized schizophrenia, lots of thought disorder, and he did seem kind of weirdly disengaged with the world. Catatonic schizophrenia is a very different thing, and it's really characterized by psychomotor disturbances, meaning that the brain seems to have struggles with using the body. So some of the things we see are things like catatonic stupor, which is where the person literally doesn't move. They'll sit in a spot and they just won't move for hours and hours. And sometimes we see a really unusual phenomenon called waxy flexibility. This is where if the person is sitting still in a chair and they seem completely flattened and disengaged with the world, maybe they've got their arms just resting on the sides of the chair. If you grabbed one of their arms and you moved it up above their head, like they were raising their hand, and then you let go of that arm, it would stay there. So that's where that waxy flexibility term comes from. They're kind of flexible. You can move their body, but then you move it to a certain point and let go, and their body will just stay kind of like a wax figure in that position. It's a really unusual phenomenon, and it's quite rare, but it does happen with catatonic schizophrenics sometimes. The last one there is undifferentiated. So this is where the person has psychotic symptoms, so those delusions and those hallucinations, that loss of touch with reality, but they don't really meet the criteria for those other subtypes. All right, so finally, we're just going to look at how we treat a condition like this. And over the course of history, there have been three typical ways. The first one being institutionalization, and we saw a bit of that when we looked at the history of the Madhouse documentary. Then we moved on to things like antipsychotic medications, and more recently, people are trying more therapeutic approaches to try and help people with schizophrenia. So the institutional treatment is the kind of historical perspective, and there is a strong and scary kind of history of institutionalization in combination with drug therapy in inverted commas there, because usually it was tranquilizing drugs, highly sedative drugs, and people with this illness were essentially just locked away and sedated. So there's huge problems with this kind of treatment. It obviously didn't do anything to help the person overcome their symptoms or get back to daily life. It essentially just removed them from the world. So then we move on to antipsychotic medication, and these are drugs that help reduce those psychotic symptoms, those symptoms of delusions and hallucinations. So we have typical antipsychotic medications, which were the first ones developed and have been available since about the mid-1950s. These are the older, more conventional drugs that treat psychotic symptoms. And they're highly tranquilizing, and they have some really nasty side effects, often including things like tremors and uncoordinated movements, things that are quite confronting to see and for the person to experience. Then in the 90s, scientists developed atypical antipsychotics, a new form of antipsychotic medication. These medications, one of which is clozapine or Clozaril, are a really effective way of treating psychotic symptoms and breaks with reality, and they seem to act on dopamine receptors. I mentioned earlier that dopamine seems to be a key neurochemical when it comes to schizophrenia. People having a psychotic episode seem to have really high levels of dopamine, so high that they kind of drop off the edge and lose touch with reality. So these new antipsychotic medications, rather than just tranquilizing the patient, they help reduce the dopamine that's flooding through the person's brain. They act on the dopamine receptors and restrict the amount of dopamine, and therefore kind of alleviate the psychotic symptoms. One of the big downsides of these drugs is that they do have a big impact on white blood cell count, so the patient often has to get blood tests every couple of weeks just to make sure that there's nothing wrong with their immunity, because the white blood cells are affected by these atypical antipsychotics. And then finally, we've got therapy. And therapy is a really tough one with something like schizophrenia. The most common type is CBT, or cognitive behavioral therapy, and that can be really helpful. But the problem is the patient usually has to be medicated to help alleviate the psychotic symptoms and actually make them more receptive to therapy in the first place. If the person is in the middle of a psychotic episode or experiencing a lot of psychotic symptoms, they may believe that the doctor is part of the conspiracy against them. They may be distrustful. They may have no insight into their illness, and they're fully in the grips of the delusions and the hallucinations, and they don't see that that's out of touch with reality, so they're not really receptive to treatment. They don't think that they need it. So often the medication has to be used first to alleviate those psychotic symptoms, and then the person is more likely to be receptive to psychotherapy. So it's a complicated thing with an illness like this. All right, so in summary today, we've dug into schizophrenia, the causes, particularly things like traumatic experiences, substance use, and things like that. The key characteristics of schizophrenia being delusions, hallucinations, altered senses, thought, and speech disorder. We've looked at some of the symptoms, the positive symptoms kind of heightening the person's arousal levels, so the delusions and hallucinations often fall into that, and the negative symptoms kind of flattening the person's arousal, so that's things like the speech alosia, the poverty of speech. I showed you a couple of case examples from my life of people that have experienced psychotic symptoms. We looked into the subtypes with paranoid schizophrenia. We looked at, what else did we look at? We looked at, I've just drawn a mental blank. Let me flick back. Looked at paranoid, undifferentiated, disorganized, and catatonic schizophrenia. So we've got those 4 subtypes there. And then we finished by looking at the treatment. So treatment being a history of institutionalization, the development of typical antipsychotic drugs, and then newer atypical antipsychotic drugs, and then the use of CBT in conjunction with drug therapies. All right, hope all that was useful, and I'll see you guys in the video conference. Thanks.